A 48-year-old woman presents with severe chest pain for 2 hours. An episode of severe retching and bloody vomiting preceded the onset of chest pain. She says she had an episode of binge drinking last night. Past medical history includes a gastric ulcer 5 years ago. Status post-surgical repair. Her blood pressure is 110/68 millimeter of mercury. Pulse is 90 per minute. Respirations are 18 per minute, and oxygen saturation is 90% on room air. ECG is unremarkable. A cardiac examination is normal. Crepitus is heard over the left lower lobe of the lung. Which of the following is the most likely etiology of this patient's symptoms? For those of you that got this right, it's correct. Okay, I mean, it is correct, but that's great. The diagnosis is Boerhaaves syndrome. Okay, that is rupture of the esophagus due to increased intraluminal pressure. The findings that point towards a diagnosis of Boerhaaves syndrome are firstly, severe chest pain for 2 hours. Okay, but once again, not very specific. Okay, episode of severe retching and bloody vomiting preceded the onset of chest pain. This is the most important. Boerhaaves syndrome usually happens following an episode of violent retching, usually in people who are alcoholics or in people who are, who are suffering from bulimia. These people, since they constantly, have vomiting episodes and kind of like very severe episodes, you can kind of suspect them, and you can kind of suspect this disease in that demographic. Okay. In addition to that, they've mentioned that she has had an episode of binge drinking last night, so you can kind of correlate the two. Like I mentioned, alcoholics, bulimics, severe retching. Okay. Her past medical history, okay, that's kind of like not relevant right now in this particular case. Hemodynamics are fine. ECG is normal. Cardiac examination is normal. A crepitus is heard over the left lower lobe of the lung. Okay. So this is your subcutaneous emphysema, otherwise called your Hammond sign. Okay, that's your HAMMAN. Don't confuse it with Homan sign. That's seen in like your deep vein thrombosis and other peripheral vascular diseases. Okay. So yeah, so subcutaneous emphysema, okay, points towards the diagnosis of an esophageal rupture. Okay, and like I said, Boerhaaves syndrome. So that is option C. Option A is a linear laceration at the gastroesophageal junction. So that is your Mallory-Weiss tear, which can also occur following severe retching, especially in alcoholics. Kind of very similar demographic, but you need to understand in this case it's going to be a painless hematemesis. The patient is not gonna come with complaints of severe chest pain and those kind of complaints the way this patient is coming with. So painless hematemesis, think of Mallory-Weiss syndrome. Painful hematemesis, think of esophageal varices. Okay, I'm not including Boerhaaves because I kind of already explained what the patient will come with, but anytime, I mean, this is just like something that I used to like help remember which one was for what. So painful esophageal varices, painless is Mallory-Weiss. Okay. Option B is horizontal partition in the tunica media of the aorta, the describing an aortic dissection. Yes, patient can present with chest pain in this case, but then the way the pain will usually be described is a tearing sort of chest pain. Okay. And in addition to that, patient will most likely have some sort of, hemodynamic instability. The pulse, everything is normal. Okay. So we can just kind of rule it out. Not just that, even if you're now going to go into the vitals, you can just very well correlate it with the fact that anyone with aortic dissection is not really going to present with hematemesis. Okay, they can present with vomiting due to the pain, but they might not present with hematemesis. Okay. Option D is Helicobacter pylori infection. They've just given this because patient has had a gastric ulcer 5 years ago, just to kind of confuse you. Yes, Helicobacter pylori infection can lead to peptic ulcer disease, which is actually one of the most common causes of hematemesis or an upper GI bleed. But in this case, like I mentioned, the fact that she's having, a crepitus and yeah, pretty much just the crepitus and also the sort of chest pain that has been described. Okay, so that alone you can kind of rule it out, because if the patient was having, say, a rupture of an ulcer, they can present most commonly with an epigastric pain. And in addition to that, if you were to take an erect chest X-ray, you will see a free air under the diaphragm. Okay, so anytime they want you to arrive at a diagnosis of rupture, they will most likely attach a photo of an X-ray. Okay, and in that you can see the free air under the diaphragm. You see that, you automatically know it's a rupture of a viscus, most commonly going to be peptic ulcer disease. Okay, so infarction of the myocardium. Okay, so this you don't really have to even think too much, just because it says ECG is unremarkable. So obviously the patient is presenting with an MI. You can suspect, depending on whether it's like STEMI or NSTEMI, you're either going to have an ST elevation or an ST depression or a T wave inversion, neither of which is there since the ECG is completely normal. So with that alone, you can very, very easily rule it out.
Thanks for watching. Please give a thumbs up and subscribe for more.